Morning, everyone. I have my timer here. I'm going to press start and I'm going to try and stick to it because I know today, as Eibhlin said and many others have said, is about you. We need to hear from you. This is not a fait accompli. This process requires more input from the stakeholders. And I'm delighted that we have stakeholders represented right across the board. We have patients in the room, we have patient representatives from patient organisations, industry and science, and that's very important. You know, I was reading The Guardian on Saturday and reading about what's happening in Greece and what Eibhlin talked about in terms of the financial implications. That's going to become more and more important. And since we sat down to start this project and to start on this steering group, things have changed rapidly right across Europe. There are patients in Greece who can't access treatment, not just for rare diseases, but right across the board. We don't want that to happen in Europe or in Ireland, and that's why this is very important. And I'll talk a little bit more about the importance of a system here, not just in recession, but outside of one as well, fair and transparent. But I think we have to recognise the environment we're in at the moment is very different to when we started this process, and we all need to work together on that. So in terms of Eibhlin Mulroe, I'm the CEO of Eibhlin, and I have that lovely background that John described. And Eibhlin is all about working from a patient-led perspective with industry and scientists and clinicians. And this group is perfect for that. Because within the subgroup of orphan drugs, I'm chairing it, and I'm going to talk through who the membership are. But we did consult with all of those stakeholders in this process. We defined where the gaps are in the system for patients, and there are unfortunately gaps. The problem is there's no system for orphan drugs, and some of you might be in the room going, what's she talking about? I don't know what an orphan drug is. That's what we describe. It's the treatments we describe for people with rare diseases. So people less than 5 and 10,000 in the population. That's how it's defined by the orphan drug regulation, which was legislated in 2000 by the EU. The second part of our vision for this group is to recommend a pathway for new orphan drugs which might fall outside the current system. It's fair to say that not all orphan drugs don't follow a pathway, particularly cancers. A lot of cancers are rare, and as has been outlined already this morning, the National Cancer Control Programme have the remit in that context. But there are other more ultra-rare conditions where there isn't a pathway for access, and there isn't a pathway for reimbursement and pricing, and it isn't very necessarily always transparent. And that's something that we've been looking at in particular. When we started in this process, the gaps were primarily with those new emerging treatments. That's probably going to change, and already the conversations I've had this morning with some very expert people in this room, you know, that is changing. We're not just talking about access to new treatments, it's access to treatments that are already on the market, for want of a better word. So in terms of who the membership of the group is, I'm chairing it. Sean Flanagan, pharmacist and member of the CPU, which is the pharmaceutical unit in the HSE. Geraldine O'Dea, the medical officer with the Irish Medicines Board. And Helen McAvoy, we kind of roped her in halfway through the year, and we very much appreciate her input from the Institute of Public Health. We've taken a lot of advice from the work of Europlan. That's kind of slightly confused with Eurordis there, Europlan. The Rare Disease Task Force, which was made up of the MRCG, Eibhlin and Gerda, which Eibhlin's already outlined. Eurordis have done a huge amount of work in this area in terms of systems, but when you look at other countries, as we did, like the Netherlands, France, Australia, Canada, the UK, systems already exist there, and it's not as clear here in some respects. So we're starting kind of on a back foot. We've looked at the consensus reports that we've built in Eibhlin with our work in MRCG and Gerda. A lot of people in this room have attended those events over the last 5 years, where we started, I think, in 2008 calling for a national plan for rare diseases, and this was one of the key issues at that time. So I suppose one of the lines, and you can read it there yourself, but in terms of the Irish healthcare system, we are unique. So there's no one system we can look at across the globe and say that would work in Ireland. We have to. It's an Irish solution for an Irish problem, and that's what we need to do today. And we need your input in it. Again, like Eibhlin, our strengths are a little bit light compared to our weaknesses, and that might change. You might have some other input for us on the strength side. As I said earlier, there are patients, and there are some in this room, who have rare diseases and are receiving treatment, who are accessing drugs for their condition. There's consensus between stakeholders, and that's very important. You know, we're all at the table for the last 5 years on this subject. We know that there are constraints within the system at the moment, but we're all in agreement that a new system is required for assessing orphan drugs. There's my timer going. And also that we needed to be transparent. And it's funny, we had an event this week on access to innovation, and it was around treatments, not just around rare diseases, and everyone was calling for the same thing. We need to know who the decision makers are, and we need to know if there's a right of appeal. The other strength would be that some rare diseases are already included in the long-term illness scheme. I'm looking at Sean, he might correct me, I think that's 1974 was the last time that scheme was reviewed, so that's a while ago, but it's a strength for those patients with particular rare conditions. In terms of weaknesses, I've talked about the current budgetary approaches are not adequate. There is no central pot, there's no central fund for orphan drugs. So if you're not within the normal course through the, as we call it, gateway number 1 of the system, which is either through the high-tech scheme or community scheme, then there's nowhere to go. And that means that our civil servants need guidance on where that budget can come from. And we're going to talk about that in more depth in our subgroup. But that's the issue. And I think the National Cancer Control Programme, we've all agreed, is a good example of where we could go in this space. Because I know there are moves to centralise what we're prescribing in cancer. And maybe that's something we need to discuss and explore more today. And you may have views on that. Delays in getting orphan drugs to patients it's not optimum here in Ireland at the moment. There's a thing called the Transparency Directive. I think it was legislated for in 1989, and I know there's a review of it ongoing at the moment at the EU. And within that Transparency Directive, patients should get access to the treatment within 180 days of marketing authorisation. That has not happened in Ireland, and there's a couple of people in the room who could let me know about that in terms of patients. So I've heard the knock. This might be how some of you feel today in terms of what you want to say in this context. But today and online, the HSE is running an online consultation, and I think you're all aware of it from today on. So if you don't get your voice heard today, or if your colleagues don't, this is an opportunity for you to do it. And the types of issues around this particular subject area is around how do we rate access at the moment to orphan drugs? How do we feel about an advisory committee set up by the Minister to manage this? How do we feel about that? Should that come from an advisory committee where patients would sit on it as well? How do we feel about commissioning at national level, agreed clinical protocols? And as a society, how do we feel about high-cost treatments and funding high-cost treatments? And I think that's an issue, believe it or not, we have to prove, both within this group but also within this room. And, you know, we often use the example of rescue analogy. I was reading again in the same paper about a lady who was trying to row around the world. And the Japanese rescue helicopter had to spend thousands to get out there and save her because the weather conditions have been so bad over the weekend that she couldn't complete her journey. I wonder if that lady had a rare condition, a life-threatening condition, would we bring the health economists in and decide whether it was cost-effective or not to save her? We have to start thinking about that, and we have to start putting people first within this space. And I think we've got general consensus about that, but we need to kind of get it down today in terms of our consultation. So this is what the new pathway we feel might look like. We're going to talk a little bit more about that within the 2 workshops that we have later on. I'm going to leave it with you because I know John needs the mic back for the next speaker. So thanks very much, and I hope to see as many of you as possible in our workshop.